going to talk to you very briefly on management of massive and submassive pulmonary emboli, this is what we use in our program. And actually, one would argue that the pulmonary emboli in our center is managed by interventional cardiologists and not by heart failure cardiologists. Again, full disclosure, some of the materials from the books I edit. One is the internal medicine book, and the other one is an interventional cardiology book. And this chapter on which I edit with Scott Lilly, this chapter was written by Clive Kieran and Dr. Sesta from Canada, and I've used some of the material from their chapters. So the epidemiology of pulmonary embolism is, in the US, it's up nearly 500,000 events occur per year, and it's the third leading cause of cardiovascular mortality after stroke and myocardial infarction. And the overall in-hospital mortality is 4%, and most occur within 4 days of admission of a PE. And we don't like to remember numbers, but you want to remember that the mortality is 4%, because the important thing to remember is once you start giving lytic therapy to these patients, the risk of a major bleed, including intracranial bleed, is 2 to 3%. So you want your therapy, the benefits need to outweigh the side effects. So it's important to know the overall in-hospital mortality and who you're going to select for treatment with for pulmonary embolism. Clearly, so it's important to risk stratify. About 25 to 35% of the PEs present with massive or submassive in submassive categories. And the mortality in massive pulmonary embolism is as high as 65%. And in submassive pulmonary emboli, it's 2 to 3%. So in low risk PEs, it's less than 1%. So as physicians, what do? We manage risk and we manage patients' expectations. So really, we need to first, as soon as the patient with pulmonary embolism is admitted, you have to ask oneself, what is the risk in this patient? And should we intervene? So a typical case is a 63-year-old patient who arrives to the ED with acute shortness of breath. Past medical history is remarkable for well-controlled high blood pressure. On admission, heart rate is 113 beats per minute. Oxygen saturation is about 91%. Patient is tachypneic with a respiratory rate of 35 breaths per minute. Blood pressure is good, 145/65. And he underwent a knee replacement 2 weeks ago. Physical exam was unremarkable, as many of the speakers said. JVD and all don't. And so is the EKG and the chest X-ray. The CT angio of the chest showed large thrombi both in the left and right pulmonary arteries, extending to the lobar branches. And his right to left ventricular ratio was markedly increased at 1.2. And the troponins were elevated. Echo showed moderately increased RV hypokinesis and dilatation. He was started on IV heparin and admitted to the ICU. So you can see some of the things which I've shared with you in this case will help us risk stratify whether they're massive, submassive, or low risk. So what does the triage involve? It involves, one is the echo and on CT and with the right to left ventricular ratio. Remember, when it's less than 0.9, it's normal. When the biomarkers are elevated, trope elevation or BNP, and then there is something called a simplified PE severity index, and I'll show you that in the next slide. So it's important to risk stratify anyone admitted with a pulmonary embolus. I usually, in my practice, look at by risk markers, that is cardiac enzymes, EKG changes, and blood pressure. And then when I'm in the emergency room, and if I'm going to see them, and then use the PE severity score to risk stratify. A score greater than 1 of the simplified PSI score is 11% 30-day mortality, so at the end of 1 month. So how do you risk stratify? Age over the 80 years old, history of cancer, COPD or congestive heart failure, tachycardia, heart rate more than 110 beats per minute, a soft systolic blood pressure less than 100, and an oxygen saturation less than 90%. So each one of those is 1 point, and so we use the PSI score, and a score greater than 1 is, as I said, is associated with high mortality. And so the clinical presentation is important. The presence of hypotension suggests massive PE. The absence of hypotension suggests submassive PE. And right ventricular strain by echo or CT and elevated cardiac enzymes are seen in both massive and submassive. If there is no hypotension or right ventricular dysfunction, then it's low risk. So very quickly, when you assess the patient, you can decide. And fortunately, unlike in acute MI, that golden hour is not there. But clearly, if one has to initiate therapy in massive and submassive PE, you want to assess them as rapidly as you manage an acute MI patient. So how do we classify PE again? Massive PE, sustained hypotension, systolic blood pressure is soft, less than 90 millimeters. They may need inotropic support. They present with cardiac arrest, or they're very bradycardic. In submassive PE, no hypotension, and there is some myocardial necrosis on cardiac enzymes, or there's RV dysfunction on echo or cardiac CT. The other changes are new right bundle branch block, and then I already talked to you about RV dilatation and the ratios, and the numbers are slightly different whether you use 4-chamber echo or CT, but generally anything less than 0.9 is normal. An elevated BNP or NT-proBNP is a marker. This figure shows what PE can do to your lungs. Look at these big clots, and this is what you're really going after in a massive pulmonary embolus. And so what our interventional cardiologists do as soon as we know that they may benefit from lytics is actually what we tend to do is what I'll discuss with you briefly is the opportunities. Whenever we give treatment, it's a risk benefit between bleeding and lysis. So non-massive PE, we could use heparin, and that's so non-massive PE is, again I repeat, a soft normal blood pressure, normal enzymes, and patient hemodynamically stable. Submassive PE, we use lytics. Massive PE, we use lytics. But if you see, there's a 20% risk of a major bleed and a 3% risk of intracranial hemorrhage. And that's a significant number. In my very first slide, person die. And if your intracranial hemorrhage is 3%, that's a big deal. So what we tend to do is we deliver lytic therapy by using an ECOS catheter, because it decreases the dose of systemic lytics, decreases bleeding risk. So this is where the interventional cardiologist has gone up to the right heart and passed through these catheters where they deliver ultrasound, high frequency, 2.2 megahertz. And if you look at the left panel and the right panel, here you can see that the ultrasound allows the lytics to penetrate better, and so the web of what they say is that the ultrasound helps the lytics to get to the plasminogen, and you can see this is a much denser net of clot, while this is much more an open clot and more lysis occurs. So the active drug delivery by acoustic streaming. So it's amazing. We always think ultrasound as imaging, echo, but here I want you to think of ultrasound as treatment, So this is the cross section of the catheter, and you can see the central core of the catheter is the ultrasonic core where they give ultrasound technology, and the outer lumen is through which you get the lytic therapy is given to the clot. And when you compare systemic lytics versus heparin and ECOS versus heparin, so you see the total lytic dose is 1/5 with ultrasound. Mortality is much. There was only one patient in the ECOS group with mortality as opposed to 4.3 in the lytic group. RV size and RV function improved in both, but there was 20% major bleed when you didn't use ultrasound. There was no major bleeding when you used ultrasound. And it's not surprising, because remember, we are using 1/5 the dose of the total lytic dose. So our hope is that similar benefit will be seen with systemic lytics. There will be decreased incidence of bleeding. But clearly, you require an infrastructure to deliver ultrasound. You need a STEMI-like activation system, and it needs a process in place. So if many of you are trying to set up a STEMI program, think of clubbing it together with an ultrasound guided thrombolytic in the setting of PE, because the setup will be very similar. Who's a candidate for ECOS? And I would say, again, symptoms less than 14 days, soft blood pressure, not responsive to fluids, the need for inotropes, bradycardia in the setting of shock, PEA, RV-LV ratio on CTP greater than 1 or transthoracic echo, and RV dysfunction. So in our program, we have a hotline where they activate this number anywhere in the hospital for massive and submassive PEs. So with that, I'll actually stop in the interest of time, and thank you.